oxygen during the periods of lack of oxygen, during the periods of bad oxygenation, and therefore the aerobic metabolism can be during the whole cycle of the relaxation and contraction. So the myoglobin here serves as the reserve of oxygen. During good blood supply, you make a reserve, and then during the lack, you will release the oxygen from myoglobin, and you can withstand the condition. If we look what are the sources for energy metabolism of heart, then when we mentioned aerobic metabolism, you know that aerobic metabolism joins at the level of acetyl-CoA that is metabolized in Krebs cycle and respiratory chain. Yes, in a respiratory chain you consume the oxygen. The question is, what is the source of acetyl-CoA molecule? And as you know, you can produce acetyl-CoA from everything, from fatty acids, glucose, pyruvate, lactate, amino acids. So the question is, what for our heart is the preferential energy substrate? And it was postulated that if you have the normal condition of your heart, that's healthy, in normal activity, then around 60 to 90% of the energy is covered by fatty acids and ketone bodies. That means especially the fatty acids are the predominant source of energy. And then around 10 to 40% is covered by pyruvate. And the pyruvate you can generate from glucose or from lactate. So if your heart is in normal physiological state and you have a normal day activity, then the preferential source of energy, that's fatty acids. Similar as you have in the skeletal muscle, you know that they typically also use the fatty acids as the preferential energy substrate. You can read in different books different numbers. Somewhere you can see that is 1/3 fatty acids, 1/3 glucose, 1/3 lactate. But I took this number from this article that reviews the energy situation in the failing heart and compared to the physiological state. Yes. So this is the source, you can look at it. I know that somewhere you can read other number, but I think that this is better source, yes, in that time. And you can see that in subsequent articles, they correspond with it, yes. You do not here speak if you have some disease of the heart. In the disease, the situation can be different, of course, yes, but right now we speak about a physiological state. If you compare skeletal and heart muscle about the glycogen that's inside, then in heart muscle cells you have lower amount of glycogen than in the skeletal muscle. Yes, and you know that in skeletal muscle you can use this glycogen as the quick energy reserve during highly intensive physical activity. Here, this capacity is limited. How you can use this knowledge in your further clinical practice, when you will go to further years, you will learn about the many drugs that can be used in the treatment of cardiovascular disorders. And today I will try to mention some of them in the corresponding part, only for you to see why it's useful to learn it. So at the topic of energy metabolism of heart, we can mention one drug that is not the first line treatment, but you can say that in some person you can use it as the subsequent treatment, as the additive treatment to something. And the drug is called trimetazidine, and the trimetazidine is drug that modulates the energy metabolism of our cells. And it's the drug that blocks the beta oxidation at the level of this enzyme, and therefore it limits the ability of our cardiac cells to oxidize fatty acids. And then the cells can use the second energy substrate, that's the glucose. And what's the meaning of this is that in some conditions, if your heart is limited by the amount of oxygen, it's for the heart better to use glucose than fatty acids. In previous semester, we mentioned the parameter that's energy equivalent. That means the amount of energy that's released from, we can say, unlimited amount of nutrient if you have 1 liter of oxygen. So the thing what limits you is 1 liter of oxygen. And the question is, what's the best substrate? From what nutrient you will release the highest amount of energy? And as you remember, for glucose, it was 4.05 kilocalories, and for fatty acids, it was 4.55 kilocalories. Therefore, if you have, for example, angina pectoris, disease where you have hypoxia in cardiac muscle, that means you have lack of oxygen, then it's better to force your heart to consume glucose, therefore giving more ATP per 1 liter of oxygen than when burning the fatty acids. So do you understand? What's the story behind this? It's not a first-line treatment. You will use other drugs, but it's one group of compounds that you will mention during this kind of disease.
Does this drug shift the metabolism of all the cells in the body?
Typically, yes, but these are those that are the most effective, and therefore it will be more sensitive to it. Here you have one review article where you can read how it's used. Here's the drug. Question to energy metabolism.
We had about the percentage of total energy. We had different numbers. Are those important?
With Franek? Or with whom? You know, this is the typical thing when we have different numbers, but I think that these are more correct. Therefore, I put here the source.
No, not this one, about the total energy.
You mean this, and that was how much?
I think it was 5.
5 is not. Heart is really high energy consuming. When it's 13, then okay, yes, but 15, I think that is quite relevant number.
It's 5% of the cardiac output. But the glucose is not 4.05, or is it? Because that's less than...
Not. Glucose is 5.05. 5. That glucose is this. And fatty acids, of course, here for fatty acids you must use some standardized fat. That's 4.55. You can look to the PowerPoint. I think it was the biochem of nutrition when it was mentioned. Any other question?
For that slide that you were on, you said 3 kilos, but it says 6 kilos on the slide. Which one is correct?
This, but it doesn't matter. It's 6. It should be 6 kilos. Yes, whether then there is mistake, but it doesn't matter. Yes, you can only say quite big amount. Yes, this number you do not have to remember. Yes, and the number of contractions you can calculate. If you have 70 per minute, you know how many minutes in hour, and you know how many hours in day. Yes, so that you can calculate approximately. Other question? So second topic is how to initiate, propagate the action potential in our heart and how to do the contraction. So, as you know, our heart has quite unique ability of the automacy. That means that our heart is able to generate the impulse inside, then by some conductive apparatus, to contact the signal to the whole heart, and then to do the contraction. So for example, if you have the heart transplantation, the new heart can, without any problem, start doing its activity. Yes? And it can do the physiological action with some beat per minute. Of course, that the whole regulation is not so excellent as in the normal heart, but still the heart is quite effectively able to do the activity, can respond to the hormone action, for example. Therefore, inside the heart, there must be specialized cells that will do the action, not from the point of contraction, but from the point of generation of the action potential. And as you know, these cells are called pacemaker cells, and these cells are able to do the spontaneous depolarization during diastole. Yes? During diastole, there should be a relaxation of the cell, of the heart, but some specific cells will produce spontaneous depolarization, and therefore they will start the contraction of the whole heart. What's important for you is that we can say that almost all our cells in heart can generate a signal. Only these cells are the quicker. But if you have some pathological conditions, that can be, for example, myocardial infarction or some ion disbalances, you can see that there will be some new ectopic places where you will generate a signal. Yes? And they can be the starting point for developing arrhythmias. As when you will learn about myocardial infarction, you will learn that some people die very quickly, and sometimes they die due to fatal arrhythmias. Yes? And even small myocardial infarction can cause the arrhythmias, therefore stopping the proper function of the heart. But in normal heart, this is prevented by many protective mechanisms, and one is that these pacemaker cells have the quickest spontaneous depolarization, and therefore they force the whole heart to go according to their pace. If you look under the microscope, and I hope that you did this with histologists, you can see the differences between normal contractile cells and these specialized cells. So here you have mentioned only some of them. Typical thing is that they do not have so much myofibrils, and what's important, especially for the function point of view, is that they have different ion channels, and therefore they have different electrophysical properties. That means that by the presence of other or different ion channels, they of course have different shape of the action potential. If we make a simple course of action, if we should describe it, how it's done, then we can say that the signal is typically generated in sinoatrial node. Yes? This node has the highest frequency of depolarization, and therefore the whole heart is forced to work according to its orders. Inside these cells, you have specific ion channels that increase the permeability of their membranes for cations. Yes? We can say that it's for sodium and calcium. In some sources, they will more prefer sodium. Somewhere they will more prefer calcium. Somewhere they say that it's combined action. For you, what's important is that the membranes are more permeable for cations, for sodium and calcium. And as you know, if you have a hole in the membrane for these two cations, they spontaneously tend to go inside the cells. Yes, along the concentration and electrochemical gradient. Yes, if you open sodium and calcium channels, these two ions go inside. And therefore, they will lower the membrane potential. The question is whether we can say lower, yes? Since you know that you have, for example, -65, and the question is what does it mean lower? Whether -80 or whether lower means closer to 0, yes? So maybe better to say is that this process will make the membrane potential less negative. That means more positive. Yes? Sometimes if you say lower or higher, then it's problematic that the examiner will understand it in different way. So the leak of the cations inside the cell will make the membrane potential more positive. That means you will go from the -65, that's the resting potential, to the level of -40. and this minus 40 millivolts that we call prepotential or threshold potential. And since this process is quite slow, and we can say it's spontaneous, we can call it spontaneous or slow diastolic depolarization. That means the cells have specific channels, and therefore they do this quite unique course of depolarization. When you reach the potential minus 40 millivolts, then you open different kind of channels that are voltage-gated calcium channels. You know that in normal neuron, the ion that stands behind depolarization is sodium. In these cells, it's not sodium. In these cells, it's calcium. So these calcium channels will make the fast depolarization. So that's the second phase of the depolarization. The first is slow diastolic depolarization, and here you have fast depolarization. And this will lead to the shift to the potential to the positive values. So we will cross the zero, and it will be slightly positive. Then you know that when you reach the peak, you must return the membrane potential to minus 60, 65. And this is done by the repolarization phase. The repolarization phase is simple, similar to the neuron. That means potassium channels that enable the leaking out of the potassium along the concentration and electrochemical gradient. After this, you will return to the very beginning, and you will start with the next spontaneous depolarization during diastole. So if we look at it at the picture, here you have the curve for the sinoatrial node cells, and these are the cells of the contractile myocardium, yes, that I will tell in a few minutes. So if you look at it, here you see the lowest point that we can say that is the resting membrane potential. You can say that here is nothing as resting membrane potential, since it will spontaneously decrease, yes? And therefore in some books they will tell you that for these cells you have no resting membrane potential, yes? Since there is no rest. So therefore you can say that is the minimal value of the membrane potential that these cells will see. So after this minimal point, you will have the spontaneous depolarization. Then you will reach the prepotential, the threshold potential. Then you have the quick depolarization phase by the calcium voltage-gated channels. And then after the peak, you have the repolarization. And this you will do, for example, 70 times per minute. So do you understand it? Second curve, yes.
What creates the plateau?
To the plateau I will go right now. This is the first curve that you must know. Second curve that you should be, as the minimal level of knowledge, be able to draw is the curve of the contractile cells. If you look into your books, you will see that you have there the type of the curve for sinoatrial node, from AV node, for the Purkinje cells and other things, yes? You can see that some are similar, some are different slightly, but what's the minimal thing, what you should be able to draw is sinoatrial node cell and the normal contractile cell. Since the normal contractile cell has also some specific characteristics. The first, as you see here you can define the resting membrane potential. Simply, here is some rest, and in this time, the cell waits for the signal coming from the Purkinje fibers. The minimal potential is also lower. Yes, it's not minus 65, but you see that it's much lower. When the signal comes, then you have the rapid depolarization phase, and it's simply mediated as for neuron by the sodium channels. Yes? So this phase, sodium, and it's different from the sinoatrial node cells. After this quick depolarization, when you reach the positive values, you have the first fast repolarization. But after that, you have some delay, and this delay we call the plateau phase. The plateau phase is quite effective protective mechanism for developing arrhythmias in the heart. In this plateau phase, you have the leakage of potassium out, but the concomitant action is the leakage of calcium inside the cells. And for some time, these two flows have the same net charge. That means that the effect on the cell potential is almost zero. You can see that there is some small decrease, but it's almost nothing. Therefore, we can call it plateau phase. What's important, in this time, the cell cannot accept the new starting point. That means that here is irresponsive to other signals. Yes? And that makes the heart to make the one contraction as the whole and waiting for the new signal. Yes? After some time, the flow of potassium comes to be bigger than the flow of calcium. And at that time, you come to the second phase of fast repolarization. So it was the first, and this is the second. Yes? Both of them are caused by the potassium coming outside the cell. And in the plateau, there was only the phase when there was also the calcium coming inside the cell. Yes? Make the total change zero. Here the flow of potassium is bigger, and therefore the membrane potential will become more negative, and at what time it will return to the resting membrane potential. Here, the contractile cell waits for the new signal, starting at the sinoatrial node, going from the whole conducting system of the heart to the Purkinje fibers, giving the new signal for the contractile cells for the new depolarization.
What is the reason for the calcium that it stops coming in, and why does the potassium start dominating?
The thing is that you know that each channel has several conformations, and you know that after some time some channels closes. So there's the time that here the calcium channel starts to close, and they must wait for the return to the negative charge to reopen, or to coming to the new possibility for opening.
So they're only open for a certain time, not
Yes.
because of voltage?
Yes, they are typically open for some time, and therefore after some time they will spontaneously close, and the flow of potassium gain the head of the peloton.
The contractile cell is not permeable to calcium like the
They do not have these channels enabling the spontaneous depolarization. That are different channels, and they do not have it.
So the only calcium enters during the plateau phase?
That's the, you know, you can say not the only, but that's the major part. You know that sometimes you have some channels are constantly opened. Yes, but this, if we do not take into account that you have in all cells some limited small amount, then these channels are the main for calcium coming inside. And as you know, that also this is the time when you generate a contraction. Yes, so the calcium here coming inside and then leaking from the intracellular reserves will generate the contraction. Yes, but this I think you did with physiologists when you compare the ECG curve plus the contraction curve. Yes, what corresponds to what inside. Here you have the curve, and beneath the curve you have the curve for the ions. So you see here the spontaneous depolarization, sodium plus calcium. Then you see the fast depolarization, the calcium, and the repolarization, the potassium. And if you look at this, you see the flow of sodium for the depolarization part, then the calcium, potassium for the plateau, and then the rest for calcium, meaning that the potassium will cause the repolarization phase. Last thing what you should take into account is that the time here is much longer than for neuron. Yes, the whole thing in cardiac muscle is hundreds of milliseconds. In neuron, you know that it's question of milliseconds. Yes, so that's other important thing, that really the neurons have different way and also different speed of generating of the signals. Why you should know this? In cardiology, you have one very big group of diseases that are called arrhythmias. I think that all of you know this arrhythmia, that's ventricular fibrillation. Is this correct? I think that all of you can see that here is no ECG curve. In none of the lead, you can see anything what is similar to ECG. So in this type of fibrillation, you can see that there is no function of the heart. Yes, there is the fibrillation. That means that irregular movement of the heart, but forming no contraction. And therefore, from functional point of view, no function as the pump. Yes, there is something doing the heart inside that we call fibrillation, but no organized work as the pump. So this is the same thing as you have the stoppage of the heart. Yes, absolutely similar thing. But you have, of course, many other types of arrhythmias, and one way how to treat them are antiarrhythmic drugs. And simply we can say that the antiarrhythmic drugs typically work as agonists or antagonists of some of these channels. Yes, so the antiarrhythmic drugs, that's quite a big group. You will distribute them to the classes, and many of them work as the agonists or antagonists of some of these channels, therefore modulating the way how the heart is generating or spreading the signal, and therefore the antiarrhythmic drugs can help you to stop or to prevent developing of arrhythmias in the heart. And therefore, it's absolutely necessary for you to know how normally the signal is generated in the heart. Question? The last topic before the break is the heart as the endocrine organ. As you know, almost all organs in our body have some endocrine function. Yes, that means that nowadays, for example, the adipose tissue is the biggest endocrine organ that we think that we have in our body. Yes, we will speak about it in the very last lecture of the semester. Before 30 years, we thought that adipose tissue is especially for the energy reserves. Right now, we know that quite a big amount of energy, of course, but also hormones is produced inside. For heart, it was also discovered that our heart cells can produce the hormones that will affect, especially, of course, the cardiovascular system and the internal environment balance. These hormones are called natriuretic peptides or natriuretic polypeptides. As you see in the name, they will do the natriuresis. That means that they will increase the losses of sodium inside the urine. If you compare it, or if you combine it with the knowledge that where is sodium, there is water, then it's logic that they will also do the diuretic effect. That means they will increase the losses of water. That means they will produce the diuresis, the total amount of urine. How they do this? It's quite simple. In the distal tubule, they block the resorption of sodium. Therefore, more sodium rests inside the tubule. and therefore more sodium and water you excrete from the body. So from this perspective, they work against the renin-angiotensin-aldosterone system. Aldosterone returns the sodium plus water in the distal tubule. These cells or these hormones do the opposite action. And since you know that renin-angiotensin, angiotensin type 2 is a potent vasoconstrictor, then these natriuretic peptides combine it with the vasodilatory effect. Yes, to be really opposite against the renin-angiotensin-aldosterone. How they do it? At the molecular level, so if we return to the first year, you know that peptides have typically the receptors on the cell membrane. Therefore, they have the receptor, and after the binding to this membrane receptor, the receptor will show its guanylate cyclase activity. That means that we call it receptor guanylate cyclase. The guanylate cyclase will generate the cGMP, that's the analog of cyclic adenosine monophosphate. Here it's only cyclic guanosine monophosphate. And as you know, cyclic adenosine monophosphate used the cyclic adenosine monophosphate dependent protein kinase. So here you will use cyclic guanosine monophosphate dependent protein kinase. And its abbreviation is PKG. So here guanosine G for adenosine monophosphate is PKA, for you to simply to remember it. And this protein kinase will phosphorylate some proteins inside the cell, inside the smooth muscle cell of the blood vessel wall, and it will lead to the relaxation of the smooth muscle in blood vessels, and therefore it will cause the vasodilation. That means lowering the blood pressure. The question is why and when these hormones do their action. So the question is, what's the stimuli for their secretion? We have these hormones, one produced in atria, second produced in the ventricles, but the signal for their secretion is the same. And that's the increased tension in the wall. And the increased tension in the wall of atria or ventricles you have if you have, simply we can say, higher blood flow into the atria and ventricles. That means if you have in total higher amount of water, higher amount of blood. That means that if you have dilation of the compartment of the heart leading to the increased tension, then the heart reacts to it by releasing compounds that will decrease the amount of fluid coming to the heart, and that can be done by the fact that they will release the sodium and water in the kidneys to the urine, and therefore the total amount of sodium and total amount of water will be lower. And this will return to the normal value, the flow of blood into the heart, leading to lower tension, and therefore the feedback will cancel or terminate the secretion of these hormones. So do you understand this regulatory loop? More blood coming to the heart, bigger dilation, bigger tension, releasing of these hormones, and therefore reducing the volume of the blood. One way how you can see that these hormones really exist is coming to the swimming pool. Have you heard this funny story? No. If you go into the swimming pool, then simply the water where you are inside will of course make a pressure on you. That means that the water from the interstitial space will be forced to coming to the blood circulation, therefore increasing the amount of blood, therefore increasing the amount of blood coming to the heart, do the dilation of the heart, and the heart will react on this by generating these natriuretic peptides. And if you are some time in the swimming pool, you know that you will feel that you need to urinate. Yes? And when you put the person in the water and you will look what's the diameter of the compartments of heart, they are of course bigger and they have higher secretion of these peptides. Yes? So that's quite artificial way how to show it, but that's one way also how this regulation is used. When we use this in clinical practice, it's quite simple. If you have failing heart, that means the heart that's not able to do its work properly. One result of the work is that it's not able to pump the blood out. And therefore, the volume of the heart increases, the heart is dilated, and in that situation, the secretion of these peptides are increased. So if you have suspicion on the heart failure in the patient, you can confirm your diagnosis by measuring these peptides. And if you see them positive, see them elevated, you can be sure that the symptoms of that patient can be caused by the heart failure problems. If they are negative, then you must look for other possible causes, for example, respiratory disorders. Question?
What symptoms you said?
Typically dyspnea, so the problems with the breath. You have the person coming to the hospital that has the dyspnea problem with the breathing, and you have several possibilities. Two most common is respiratory problem or heart problem. If you measure these and you see them negative, then you can be pretty sure that heart is okay. It's not 100%, but the probability is quite low. Therefore, you can focus on the respiratory problems. If you see the symptoms and these are positive, you can be pretty sure that the heart problem is inside. Of course, it can be combined with the respiratory one, but you can be pretty sure that you must treat the heart also. So, if you have no question, then we will break till 37. We'll have hypertension. It depends how you do the criteria, of course, but you can be pretty sure that it's around 1/3 or more. Yes? So it's a very big problem nowadays. The people nowadays typically do not die due to hypertension, due to malignant hypertension, as for example Eisenhower did. But what right now is that the people die due to the complication. Yes? If you have the typical person with hypercholesterolemia, diabetes, and high blood pressure, plus combining with the smoker habit, then you can be pretty sure that the cardiovascular disorders come sooner than later. Yes? And therefore, it's quite important for you at this level to know what are the parameters for normal blood pressure and how our body does the regulation, since you will use them in the pharmacological treatment. As hypertension is typically in majority of causes treated by pharmacological treatment. Before we come to the factors, you should be aware of the fact that there are some factors that you simply cannot change. Yes, for example, the age. The older you are, the higher blood pressure you simply have. Yes. Between genders, you have also differences. Yes, males have typically slightly higher blood pressure than females. There are some differences in races. And of course, some drugs have as the side effect the modulation of the blood pressure. Yes. If we take these factors out and we take the basic physical point of view, then we can say that arterial blood pressure is modulated by only two factors. And that's the cardiac output, that means the function of the heart, and total peripheral resistance. That means the tubes where the blood is flowing. So from the physical perspective, it's the pump and the tubes. And of course, the third characteristic is the liquid that's moving through the tubes, and that's the blood. If we look at these two characteristics, then we can say that each of it is dependent on two sub-characteristics. So you know how to calculate cardiac output. Cardiac output is the multiplication of frequency and stroke volume. If you know two basic numbers, that's the frequency and cardiac output, you are able to calculate the cardiac output. So if a simplification is that it's 70 multiplied by 70, you know that the result is around 5 liters. Yes? So you do not have to remember the number, you can quickly calculate it. That's the first thing. Second thing is the peripheral resistance. The peripheral resistance is dependent on two factors also, and that's the quality of resistance arteries. That means especially their diameter and the length, and the characteristic of the blood, of the liquid, that's the viscosity. And right now we will go through all these factors and we will describe them, and we will show, or I will try to show to you how do we regulate it in the physiological manner. So if we start with the simpler, that's frequency. As you know, the frequency of the sinoatrial node is autonomic. That means that the cells will generate a signal in autonomic pattern, but it doesn't mean that we cannot regulate it. We can regulate it, we can increase it, or we can decrease it. And the two main systems that do this is the nervous system and the endocrine system. We can say that you have two possibilities, that means the increase or the decrease of the frequency, and this we describe as the chronotropic effect of some compound. So if you increase the frequency, we call it positive chronotropic effect, and when you decrease frequency, we call it negative chronotropic effect. Of course, that if you have two signals with the same strength, then the result is 0, yes, and the frequency is unchanged. So the positive chronotropic effect typically express the sympathetic nervous system and the adrenaline produced from the suprarenal gland. So in general, you can say catecholamines, and it doesn't matter what the origin of the catecholamines. Second side, that means negative chronotropic effect, is typically done by the parasympathetic nervous system. That means by the acetylcholine. How at the molecular level it's done? The catecholamines, they have their specific receptors. As you know, we have alpha adrenergic receptors and beta adrenergic receptors. Alpha receptors have two subtypes, alpha 1 and alpha 2. And beta receptors have 3 subtypes, beta 1, beta 2, and beta 3. One of these groups we call cardiac receptors, and that are the beta 1 adrenergic receptors. So these receptors stands behind the fact that the cardiac cells react to the catecholamines in the way described here. All beta receptors are coupled with GS protein. That means the protein that's coupled with adenylate cyclase, and it will lead to the increase of concentration of cyclic adenosine monophosphate in the cell. This will lead to the activation of dependent protein kinase, that means protein kinase A, and this will lead to phosphorylation of target proteins. You have many of proteins that are phosphorylated. What's important for us now is that you will phosphorylate the calcium channels, leading to the faster influx of the calcium inside the cell. And therefore, if you have faster influx, then the generation of the signal in the respective cells is quicker, and therefore the frequency is increased. So the easier you do for calcium to coming inside the cell, the quicker the generation of the impulse will be. Here on this picture, the Protein kinase A, as you see here, is the place where you will spread the signal to many places. So here is, for example, the metabolic effect, and here is the effect leading to the phosphorylation of the calcium channels, increasing the amount of calcium and therefore increasing the rate of generation of impulses. We will return to this effect in some time when we will speak about the positive inotropic effect. That means that adrenaline increases the contractility of the heart. That means the strength of the contraction, since that's done also by this calcium. Yes? But right now, we spoke only about the depolarization, and that's done by the beta-adrenergic receptors by this mechanism. If we look to second, to the opposite, that means the acetylcholine action. The acetylcholine action is enabled by two types of receptors, nicotinic and muscarinic. Nicotinic, right now, we can forget, and we can stay at the muscarinic receptors. As you know, muscarinic receptors have 5 subtypes, and in the heart, we have the M2 receptors. So these are the cardiac muscarinic receptors. And M2 are linked to opposite G protein than GS. That means to GI protein. And what they do is simply, they do the opposite thing. That means they will decrease the level of cyclic adenosine monophosphate. Therefore, you will develop the dephosphorylation. As the result, you will make the calcium flow weaker. Plus, they concomitantly will lead to opening of potassium channels. Therefore, the potential at the very end will be more negative. So if you look into your books, we have the curve of the sinoatrial node. Then if you have the action of the sympathetic nervous system, here the curve much quicker reaches the threshold. And if you have the parasympathetic tone, then the curve reaches the threshold later. And that means that here you have lower frequency and here you have higher frequency. Simply here you quicker reach the threshold, and here the threshold potential is postponed, the reaching it. Question? If you have the frequency 60, 70, what's more dominant, sympathetic or parasympathetic nervous system? That means in the resting state of your heart. Parasympathetic is in quicker action. So if you switch off parasympathetic, that is the first thing how you can increase the frequency. Yes? If you have some highly intensive stimulation of parasympathetic nervous system, it can for some time stop the heart function. Yes? So you can have, we can say, cardiac arrest if you have very intense function of parasympathetic nervous system. How we use this at the pharmacological level? Do you know some drugs that are used to increase or decrease frequency? That are routinely used each day? So what will do beta blockers? What is the result of their action? Increase or decrease of frequency? Decrease, since they will block these receptors, therefore slower rate of generating of the impulses.
Well, they use sometimes non-specific beta blockers.
In different situations, you can use different. You have selective, cardioselective, non-very specific. Sometimes they have different action on beta 1 and beta 2 receptors. In different occasions, you can use different. Yes. For example, in the combination with asthma bronchiale, you want to have the blocker that, for example, blocks the heart, but activates beta 2 to dilate the blood, the bronchi. Other drug that will work on this. And that's routinely used, for example, at anesthetic departments, at the operation room. That's atropine. If you block this, you will increase the frequency. So atropine can be used to increase the blood frequency, the heart frequency. Second characteristic is the stroke volume. Stroke volume is simply defined as the amount of blood that pumps in one contraction from the heart. And this stroke volume is determined or influenced by three characteristics, by three values. The first is preload, the second is afterload, and the third is contractility. And each of them can be modulated by the hormones or by the nervous system. So if we look at each of them separately, if we start with the preload. For preload, you can read many definitions. Here I use the definition that explains that it's very similar to one parameter of the skeletal muscle. Yes, since you have already the skeletal muscle, so I will try to use the similarity with the skeletal muscle. This definition says that the preload can be understood as the length of the myofibril before the contraction. That means at the very end of the diastole. So why we can use this definition? If you have skeletal muscle, you know that the sarcomere in the skeletal muscle has some ideal length. That means that in some ideal position, at some ideal length of the muscle, you have the best interaction between actin and myosin. If you have the distance of sarcomere bigger, then the interaction is worse. And the same if the length of the sarcomere is smaller than some ideal value, the contraction is also worse. Yes? The problem is that the myofilaments cannot interact in ideal condition. The same we have for the heart. The only thing what makes the heart more problematic is that in normal skeletal muscle you have some origin, typically two bones, and in the heart you have nothing. Yes, we do not have bone, so it means that in the heart you must work with the volume. Yes, you have the ventricle, and the ventricle has the volume. And therefore the same parameter as the length of the myofibril is the end diastolic volume. If you make the end diastolic volume bigger, that means the length of the myofibril will be bigger. If you make the end diastolic volume smaller, then the length of the myofibril will be smaller. And for your heart, you have also some optimal end diastolic volume, and you have some optimal length of the myofibril. And the thing is that in our heart, if you are at the normal end diastolic volume, that's around here, you are not at the point of the ideal situation. So you can say that in the normal activity with the normal end diastolic volume, your heart works not in the ideal condition. And therefore, if you increase the end diastolic volume, as you see in this curve, you increase the stroke volume. That means that the result of the heart function is better. And this postulates the frankstarling law that tells you that the bigger the end diastolic volume, that means the volume before the contraction, the better action of the heart. That means that the systolic output will be bigger. As you see here, you can reach some ideal point, and after this time, when you reach the peak, you will go down. So the situation is very similar to the skeletal muscle. Here you see that here you have much better organizing of the sarcomere. And when you are somewhere here, you have too big distance, and therefore the interaction is not ideal. The thing what makes the difference between skeletal muscle and heart muscle is that skeletal muscles, they typically at the normal organizing should work at the ideal length. Here, the heart has the reserve. That means that when you start doing the physical activity, here you have the physiological reserve where the heart, without no much bigger work can increase its effect. That means increase the stroke volume and therefore leading to better vascularization of your tissues. Yes? So that's the characteristic, the preload, the length of the myofibril, or you can say the dilation of the heart at the end of diastole, and the basic parameter till around 300 milliliters of end-diastolic volume when the result is bigger. So you can say that end-diastolic volume determines the stroke volume. The preload can be therefore defined by the end-diastolic volume, by the length of the myofibril, but it doesn't matter. Yes, if you will explain it in this way, and you will use your definition or definition from the book, but you will explain what the relationship is okay. The question is how we can say how big will be the end-diastolic volume. The end-diastolic volume is dependent on two characteristics. The first is on the venous return. The venous return is the pressure under what value the blood is coming into the heart. Yes? So that means that you can say that is the pressure of the liquid that forces the heart to dilate during the diastole. And you know this value for the central venous pressure for the right heart. That means the heart coming from the whole body. Yes, the value is central venous pressure. Second important characteristic is the compliance of the ventricle. Since you want to dilate the ventricle, and therefore this is dependent on the quality of the ventricle or atria wall. So if the compliance is okay when the heart is healthy, then you will gain this type of curve. That means that the heart will dilate quite easily. Problem is, if you have some diseases, that will limit the compliance of the heart wall. In that situation, it's very difficult for the heart to dilate. And in that situation, the law doesn't work. Yes? But if you are healthy, then typically what your body modifies is the venous return. That means when it needs to increase the stroke volume, it will increase the venous return. If you have other situation, that it can decrease it. And how you modulate the venous return, and that means how you modulate the preload, is mentioned here. So the venous return means the amount and the pressure of the liquid coming to the heart can be modulated by two things. First is to modulate the amount of blood. So that means all parameters that regulate the amount of liquid in the body, therefore limiting or increasing the amount of blood coming into the heart, will modulate the preload. And here you have renin, angiotensin, aldosterone, and atrial natriuretic polypeptide as examples. Second possibility is that you can modify the volume of the vascular bed. You know that you have some physiological distribution of your blood inside the blood circulation. Where you have the highest amount? In what compartment is the majority of blood stored? In veins. That means that if you take venoconstrictors that will constrict the veins, you will increase the preload. Simply, this constriction will force more blood coming inside the heart. So one way how the heart can increase the preload is by constricting the circulation, therefore forcing more blood coming inside. And as you know, this constriction can be very effective. If you have blood loss beneath 1 liter, the constriction of the vascular bed is able to compensate it. Yes? So if you are a donor of the blood and they will tell you some normal amount, your blood circulation is able to compensate it, for example, by the compression of the veins. Yes? And they will use this reservoir to feed the heart with adequate volume. Of course, if you have vasodilation, that means if you have, for example, anaphylactic shock, then you have in your whole body vasodilation, and the result is that the reservoir is bigger, and therefore the preload is lower. Therefore, the systolic output, systolic volume is lower, and the cardiac output will be lower also. And the heart pressure will be lower. How you can do it as the doctors? Quite simple. If you give fluids to the patients, you give liquid, therefore you will increase the preload. If you give diuretics, you will remove the water, you will reduce the preload. Question to this? As you see here, we mentioned nothing about the compliance. Simply, right now, we are not able to modify the compliance very effective, and therefore you can typically read that the preload is the same as venous return. For the normal healthy heart, it's true, but if you have persons that have, for example, accumulation of some waste compounds in the heart, the compliance of the heart wall will be lower, and that will limit the preload. Yes, but in normal healthy heart, you can say venous return is preload, and that modifies the systolic volume. Afterload. Preload is the situation at the end of diastole. That means how big is the volume of the ventricle at the end of diastole. Afterload is the second characteristic that modifies the stroke volume, and we can say that it's the pressure that our heart must generate to overcome the resistance in the circulation. So right now we shift to the systole, to the beginning of the systole, since you need to open, for example, the aortic valve. And the question is, how big is the resistance in the circulation? And therefore, we can say that afterload is the same as the peripheral resistance from the point of view of the vessels. And as you know, there are two characteristics deeply modulating the resistance in the tubes, in the blood vessels. That's the length and that's the diameter. Is length important for us if we are adult? Not so much, since if you are adult, you have the final size of your body, the length of your circulation is final. Yes? So our body is not able to actively make the capillaries shorter, yes, or make shorter the aorta. That's unfortunately not possible. That means that almost everything here is only about the diameter. And as you know, only some cells can, or some blood vessels can actively modify the diameter. For example, capillaries cannot do it. The most effective place for the regulation are muscular arterioles. And the diameter modifies the afterload, and therefore it modifies the systolic volume. Here you have many factors that modulate it. Here you can mention, for example, angiotensin type 2. Here you can mention adrenaline, noradrenaline, and other things. Today we will focus only on two groups, and that are the groups of endothelial cells and the group of metabolites. Yes, the adrenaline and the other, please review at home, or you should do them with the physiologist. So if we look at the first, that means the concert of epithelial cells and the smooth muscle cells in the arterial wall. You know that we have two groups of compounds, local vasoconstrictors and local vasodilators. Here you have per each group two of them. I choose them by the pattern that first they are important, and second that they have different chemical property. For each of them, you should know what's their chemical property and how they are produced. So vasodilation. NO means nitric oxide. You know that the second name of it is endothelium derivative relaxing factor. but it's still the same compound, and it's the simple radical derived from arginine. And it's a very, very potent vasodilator, working in very similar pattern as natriuretic peptides, only the guanylate cyclase for it is located inside the cells. So we call it soluble guanylate cyclase, and the mechanism of its action is absolutely the same as for the natriuretic peptides. Prostacyclin, how do we produce it? What's the maternal compound for it? So it belongs to a group of eicosanoids, and the maternal compound, arachidonic acid. So it's derivative of lipid. Vasoconstrictors, endophelines. What's their chemical nature? Yes, they are peptides, so that means derivative of amino acids, but as the peptides. They are very potent vasoconstrictors, and they do the action of some of these compounds. For example, the angiotensin type 2 do its very strong vasoconstrictor action with the help of endophelines. Yes? And thromboxane A2 was the maternal compound for it. No, it is also the eicosanoid derived from arachidonic acid, only the enzyme is different. Thromboxane is produced in your thrombocytes also. And thromboxane A2 is the compound that during the stoppage of bleeding causes the constriction of the damaged vessel. So not only endothelial cells, but the immune cells, or for example the thrombocytes, produce these compounds also. And as you know, during the stoppage of bleeding, you want to have the constriction of the blood vessel, you want to have action of thrombocytes, and you have the coagulation. And thromboxane A2 combines these different groups. Second is the group of metabolites, how we can say it in general. That means the metabolic situation in the tissue will modify the afterload, yes, the resistance in this tissue. You know that this local effect is especially important in heart and in brain. Yes, our heart and brain modifies the blood flow according to the needs of their metabolism to a very big extent. Here you see the main. A lot of oxygen leads to vasoconstriction. Lack of carbon dioxide leads to vasoconstriction also. The thing is, if the tissue has enough oxygen and the carbon dioxide is not accumulating inside, it's no need to increase the blood flow inside. And it's combined with the pH, since low accumulation of acid means high pH. In working tissue, you have the opposite situation. Lack of oxygen, lot of carbon dioxide, and low pH. Low pH due to carbon dioxide or lactate accumulation. And therefore, you should do the vasodilation. There is one tissue in our body when it's not according to this rule, but it's opposite. Where it is? Lungs, and why? That's true. That means that the function of the heart is of lung is opposite. The good ventilated alveoli should be also well perfused. That means if you have the oxygen in the alveoli, the blood should come inside this or close to these alveoli to be oxygenated. Therefore, in lungs, you have it opposite. In other tissues, you have it according to this rule. Adenosine, how do you produce it? So it's in the last in the row. ATP, ADP, AMP, adenosine. So adenosine means the tissue is lacking energy. And for example, your heart, when you have the accumulation of adenosine, it will lead to the vasodilation of the respective area. Question to this? So, right now we have the situation of the heart. After the diastole, you know the volume. Then the afterload will tell you what's the resistance in the periphery. And if you make these two parameters constant, then still your heart has one parameter how to modify the stroke volume. And that's the contractility. That means how forceful will be the contraction. Since your heart can make the contraction stronger or weaker. So this is the last parameter that determines the stroke volume. And here you have two things what you need to have for normal muscle contraction. So first what you need is to have energy. That means oxygen and nutrient. So if your heart has the myocardial infarction, the thing is that the region that should be supplied by the occluded blood vessel simply cannot work. And if you look at it at the echo, you will see no movement. Simply there is no energy, no nutrients, no oxygen, therefore no work. Second parameter is the intracellular concentration of calcium. And here we return to the fact that we learned for the frequency. So how we can modulate the strength of the contraction, we typically can do it by the sympathetic nervous system, by the adrenaline. We will use the same receptors. By the beta-1 adrenergic receptors, you will increase the amount of calcium inside the cell, and therefore the whole contraction will be stronger. The mechanism is the same as we described with the frequency, only here we look at it from the point of the contractility. And more calcium means higher contractility.
So you can only increase both frequency and contractility?
You typically increase both. What you can do is in the concomitant action of parasympathetic nervous system, you can reduce the frequency effectively. And the explanation for this, you know, since the innervation of the heart of sympathetic and parasympathetic nervous system is not the same. Sympathetic nervous system comes to the ventricles. Parasympathetic nervous system typically does not come to the working apparatus. It innervates especially the conducting system. Therefore, the parasympathetic action is not on the strength, on the contractility. Have you heard about digoxin? If you would be here 40 years ago, you already heard about it many times. It was a drug that was routinely used to treat the heart failure. And does somebody of you knows how does it work? You know, this is quite funny. I also learned it when I was in, I think, 3rd or 4th grade. And it's quite funny since it works on one protein that you routinely know, since it's one protein that if you do not know, then you will fail during each exam. And the protein is called NAK ATPase. Since NAK ATPase, as you know, transports the sodium outside the cell and potassium inside the cell. And as you know, in cardiomyocyte membrane, you have the second transporter that pumps calcium out the cell, and the sodium comes inside the cell. And what happens if you block this? Then the sodium accumulates in the cell, and therefore the second pump cannot work effectively. Simply here you have lower gradient for sodium. So the result of digoxin action, if you block this, is that you increase intracellular calcium. Simply, it cannot be pumped out the cell. Yes? So digoxin is the drug that blocks the ANK ATPase, and therefore in heart it increases the contractility. Why it's not used today is that it improves the symptoms. You can say that the patients feel better, but the prognosis are worse. Since this drug increases the arrhythmic periods in the patients. And therefore they have better outcome. You can say that they feel better, but the life expectancy is worse. And we have other drugs that can help them. Will you give me 2 more minutes? So do you understand preload, afterload contractility? Last parameter that was mentioned in blood pressure is viscosity. Here the story is very, very simple. You have the liquid, and viscosity describes, we can say how easy it is to pump it, if you look at the perspective of our heart. So to pump water is quite simple. The viscosity of water is 1. We do not have water, we have plasma. Viscosity of plasma is 1.5. So it's more difficult for the heart to pump it. But we do not have plasma, we have plasma plus corpuscles inside. That makes the viscosity 3. So that's a normal situation, and our heart is well equipped to pump the blood. What can happen is that you can increase the amount of proteins or particles inside. Both of these will lead to increase of the viscosity, and therefore it's more difficult for the heart to pump the blood. Yes, it's much bigger work. The fact is that unfortunately you can do anything with it. Or you can say that we have compounds that will modulate these parameters. For example, erythropoietin modulates the viscosity, of course. If you have more erythropoietin, you have more red blood cells, therefore viscosity is bigger. But erythropoietin is regulated by the partial pressure of oxygen, not by the work of the heart. So from the perspective of blood circulation, the viscosity cannot be regulated, yes, but it will influence its action. Do you understand it? Yes?
If you have some hypervolemia, you also decrease the...
Yes, if you have patient after the bleeding, you will give him only liquid, not corpuscles, then the viscosity will be lower. So you can see that here is the relationship between hematocrit and viscosity. If you lower hematocrit, then you lower the viscosity. So if you have patient after bleeding, in first aid you give him only liquids, you will decrease the viscosity. And here the last, you see drugs that you will routinely see to treat blood pressure. That means hypertension. On the first place, ACE inhibitors and sartans. Both these compounds block the renin-angiotensin-aldosterone system. Each of them does it at a different level. Each of them very effective drugs. Beta blockers, we describe it. You block the adrenergic action on the heart, therefore reduce the chronotropy, reduce the inotropy, and therefore you will reduce the blood pressure. Third option, diuretics. You will increase the diuresis, you will reduce the volume, therefore you will reduce the preload, you will reduce the blood pressure. And here you have some others that are not so routinely used, but altogether you will learn about 6-7 big groups of antihypertensive drugs. But these 3 are the main if we take these together as one. That means against renin-angiotensin-aldosterone system.